Good evening. It's now 6:05 p.m. Wednesday, July 19th, 2017. And this board, or it's time to call this workshop special called meeting of the Board of Trustees of San Felipe Del Rio CISD to order. Ms. Haynes, would you call roll, please?
Yes, sir. Mr. Chavita? Mr. Mesa?
Here.
Mrs. Martinez-Lozano?
Present.
Mr. Overfelt?
Present.
Mrs. Gonzalez?
Here.
Mr. Smith?
Present.
Myself.
Thank you, Ms. Haynes. We have a quorum.
Yes, sir.
Let the record show that a quorum of the board members are present, and this meeting has been duly called, and notice of this meeting has been posted in accordance with the Texas Open Meetings Act, Texas Government Code, Chapter 551. This time, if you please stand for opening ceremonies, first with a moment of silence, followed by the Pledge of Allegiance.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. All right. Next on the agenda is school board workshop, which we're going to open. There, just a reminder or an update to everyone who's in attendance. It is a workshop, so there aren't any public comments on anything this evening. It's just purely informational. Public comments would come at the next regular board workshop there. So we won't be taking anything on that as per Texas Government Code 551 and BED local, which handles public comments. So, Ms. Valdez, the 2017-18 budget workshop dealing with health insurance. The floor is all yours.
Thank you, sir. Good evening, President Overfelt, Dr. Rios, board members. Tonight, for this workshop, we will be presenting the 2017-2018 medical and prescription benefit plan. This plan was presented to the Health Insurance Committee last week, and this plan is what we have compiled after working with the committees since the beginning of this year. We're also integrating the survey results from the employees, and again, any input from the committee was also considered. I will turn it over to Mr. Mike Getz now. He's from Gallagher Group. He is our health insurance consultant. But myself and Laura English and Mr. Getz will be presenting tonight. Thank you.
Thank you very much, Mr. President, Dr. Rios and board. I appreciate the opportunity. And first of all, I'd like to thank our committee members who are in attendance today for this meeting. They put a lot of their own personal time and effort into this whole process. And I can say that it was very educational for everybody that was involved. So I definitely want to acknowledge their participation in this process. And so first of all, I just wanted to, at a high level, give you an overview of kind of where we're at and why we're looking at the things that we're looking at throughout this presentation. The data that we're looking at is actually through April of this year, but I can tell you in seeing May and June's data that our trend hasn't changed much, maybe 2%. But through April of this year, we've spent our contributions totaled $6,176,328. 85% of that, or $5.252 million, came from the district, and 15%, or $924,000, came from the employees for dependent contributions and their cost toward the cost of coverage. As far as what we are spending, year to date through April, we've spent $7.564 million. Of that, almost 5.6 was medical claims, and just under $2 million were prescription claims. So our medical is actually trending through April at 21%, and our pharmacy is trending at 9% over last year. So that leaves us year-to-date with a deficit of about $1.388 million and a projected year-end deficit of about $2.082 million. On the next slide, this is a copy of the report that we've been reviewing with the Benefit Committee on a monthly basis, just to keep them updated with respect to where we're at relative to contributions to the plan and spend from the plan, and whether or not under our self-funded plan stop-loss reinsurance we've received any stop-loss reinsurance refunds. And as a note, year-to-date we haven't received any stop-loss reinsurance refunds because we haven't had any claimants exceed their individual specific deductibles so far. So while our plan is not necessarily performing as well as we would like it to, it's not necessarily because of large claimants. What we're seeing right now this year is a significant amount of general utilization. All right, and then on the next slide, what we've done is we've taken the year-to-date results and our projection for the plan year 16-17, and we're showing we should end up somewhere in that $11.5 million total plan cost. And if our trend were to continue for the upcoming 3 plan years following this one, we would be looking at a 12.468 budget for next year, a 13.405 in 2018, and 14.435 in 2019. So, in looking at the plan performance, we know we've got to make some changes, obviously, because first of all, we're not funding up to our expected claims, and we're seeing significant general utilization. So we're looking at some things that we can do to impact that. And first of all, the first change that we're looking at is a plan renewal date change from the 9/1 date to a 1/1 date. And there's no benefit or rate changes until 1/1. If we make that, we would keep the same plans and benefits that we have today until 1/1 of 18 if we make that move. We do a partial open enrollment this year for people at September 1 who were expecting to be able to add or drop dependents or make plan changes. So for the September 1 renewal date, we'd still let people make those changes because they weren't aware of the possible move to a 1/1 date. But then we'll have a mandatory full open enrollment for everybody. Everybody would have to re-enroll for January 1 because we're going to change that renewal date. We're also going to go out to bid under the TASB Pharmacy Collective for pharmacy benefits. We believe that there may be an opportunity to save some money on what the pill actually costs the plan through that process. If we were to move, it would only be because the difference in the cost of the pharmacy plan would be substantial. We are aware that TML has negotiated a new rate with Optum RX that will be effective 1/1 for you all. And so when they quote this through the RFP process, they're going to quote with the new rates, and we think that there's going to be savings to be had by staying with TML as well. So when it comes to pharmacy, if we can avoid making a change, we'd like to avoid making a change because when you change pharmacy, it can be disruptive. We will be implementing a wellness and biometric screening program, an annual exam program for 2019, and so we'll use all of the rest of this year and 2018 to communicate the terms of that program to participants under the plan and give them an opportunity to be prepared for a 1/1/2019 program, which would affect the rates they pay to be on the plan. We're looking at having a full rate for people who don't participate in the wellness program, and then a wellness rate for those who do. But again, we've got to give people time to comply with that program during 2018 before it impacts their rates in 2019. Oh, yes, and then most of what we're doing here came from the survey. You know, a lot of the responses to the survey were pretty clear that people felt that wellness in particular was something that we should be rolling out here, and if one didn't participate in the plan's wellness programs, that they should be charged accordingly. And so that was directly from the surveys. And then we also did surveys within the insurance committee, and it essentially reaffirmed a lot of what we saw from the employee-wide survey. So, what we have here is basically just a chart that shows the current plans that we offer today and 3 options that we were looking at relative to our financial situation and what could we actually afford here. And so at the top, we have our basic plan, our high plan, and our high deductible health plan. And so our basic plan and high plan, those are standard PPO plans with deductibles and out-of-pocket amounts and then office visit copays, all right? And then our high deductible health plan, it covers all the same things that the PPO plan covers, but those expenses go toward their deductible until that deductible has been satisfied before the plan pays. Now, there is an exception to that, and it affects all plans. All plans still have to cover wellness exams, routine annual exams at 100% no out-of-pocket cost to the covered individual. So regardless of which plan an individual is enrolled in, they get their wellness covered at 100% as long as they stay in network, okay? And then on the high deductible health plan, one of the biggest differences on that plan from the PPO plan is on the prescription piece. On the prescription piece, you actually pay for the cost of your prescription out of your pocket if you're on the high deductible health plan until your deductible's been satisfied. And then after that, once your deductible's satisfied, then you pay the copay for those prescriptions, whatever the applicable copay is. We know we've got generics, in fact, at no cost, so they would be able to get their generics at no cost after their deductible's been satisfied. Now, the IRS has identified what they refer to as wellness drugs. There's a list of what they call wellness drugs, and if the drug you're taking is on this IRS list, then you actually don't have to satisfy that copay first under that high deductible plan. You just have to pay the copay. And so whenever we're counseling folks about the high deductible health plan, one of the things that we coach them to do is have a list of their medications, and they can look at that list of wellness drugs to see whether or not their drug is on that list, and if not, you know, get them an idea of what the cost of that drug is up until that point their deductible's been satisfied. And so you can see in the leftmost column, we've got the individual deductibles, and I listed everything here on an individual basis. If you have family coverage, it's a multiple of 2 times. So for instance, on the basic plan, today it's a $750 deductible. If you have a family, it's a maximum of $1,500 in deductibles, okay? So we've got $750 on the basic, $250 on the high plan, and $1,300 on the high deductible health plan. And just so you know, the IRS tells us what the minimum deductibles are on the high deductible health plan and what the maximum out-of-pocket amount is on the high deductible health plan. They set those.
Excuse me, at your seats, we did leave a chart of what the current 2016, 2017 rates are. So, and that's what's reflected here. That is the information that is on our website as well.
And so as you look through this, you see that on the out-of-pocket maximums, the first section of individual medical out-of-pocket maximums does not include your deductible. That's the 20% that the patient pays while the plan's paying 80%, okay? It's the individual plan out-of-pocket maximum that's the patient's maximum liability, and you can see regardless of which plan an individual's on, their maximum individual liability is the same. For office visits, and this is where it starts to speak to why our costs are running like they are today. On the basic and high plans, we have office visit copays. It's $30 for a primary care physician, $50 for a specialist. So that means that every time a covered individual under those plans goes to the physician's office, the plan is making a payment. Sure, the covered individual is paying their copay, but then after that, the plan is making a payment. And of course, the most frequently used benefit under the medical plan is the office visit benefit, right? Because people go to the office visit more than they do anything else under the plan. And so when we talk about general utilization, part of what's happening in that general utilization world is with the bulk of our membership, over 99%, I think, 98% of our membership is in the basic or high plan. Every time they go to the physician's office, the plan is making a payment. If they had been on the high deductible health plan, they would have paid for the physician's office visit out of their pocket until their deductible had been satisfied before the plan starts to make any payments. So when we look at the options here, go ahead.
Are there any questions on the current status? And the reason, this chart right here is the chart that I would like for y'all to tear out when we start looking at the different options so that you can see what the basis is of how the different options were calculated. But Mr. Getz explained to you what we currently have, which is the first section. And then, as you can see, the next section says option 1, option 2, and option 3. Those are related to the following slides. So again, I would recommend if you could, once we get to the following slides, if you could rip this page out so you could have it side by side as we're going through the other options.
And so I'm not going to go through in detail what the benefit options look like till we start looking at the pricing on these. But you can see in the option 1 status quo option, what we're saying is we're going to keep the same plans. What's that cost? And then option 2, if we paid the same rates, if employees paid their same share and the employer paid their same share, what kind of a plan could we buy with that? So that number is about $9.3 million, by the way, that the district and the employees kick in on an annual basis for the plan. And so basically option 2 is, what can we buy with $9.3 million? Okay, and remember that when they set the rates on all of this stuff, they're looking at the age, gender, geographical location, and health status of our group. Okay? And then option 3 is kind of in between, what if we made no changes, or what if we only bought what we could afford? What falls in between those two? Okay? Because if we look at, no changes to the plans, and it's a $12+ million budget, or we look at no changes to the rates and we're at $9.3 million, there's got to be something in between those two numbers that we can afford. And we're hoping that something similar to what we're looking at here in the option 3 will be that something, or that we can at least tweak that model some. And again, I just want to remind you all that regardless of which plan option people end up on, they still get that wellness covered at no out-of-pocket expense. Okay, so the way to read this is a contribution rate table that shows, based on plan and tier of enrollment, what the employee cost would be per month. Yes, ma'am.
I'm not sure if audience members would actually like to see what's on. Is there any way to make it bigger? So if there's any way to make it a little bigger so we can all follow along?
There's one, this would be the current
Right.
part.
So let's talk
play
about
with the
that
mechanism.
first, and then we'll slide over to the.
I'm sorry.
I'm going to ask if the board wants to recess for 10 minutes. That way copies can be made for the public.
Okay.
Is there a motion to recess?
I make a motion.
All in favor? Thank you. 10-minute recess.
Please make copies of the
Of recess at this time. Everyone has a copy. Everyone got a copy that they needed. After the presentation, after the workshop portion closes, we'll go in and have full packets
Yes, sir.
made so that anyone who wants a full packet of the presentation may have one. Those will be available afterwards. Also, after the board closes the workshop out and goes into regular business, eventually we will go into closed session for some items. They're dealing with personnel. Ms. Valdez and the representative from Gallagher will be here to address any questions you may have that might come up, because during the workshop, there will only be the questions that come from the board. We won't be able to take anything from the audience as per the Texas Open Meetings Act and those chapters that guide all of that. So if anyone has any questions about anything that gets discussed here, Ms. Valdez and the representative from Gallagher will be available after the board goes into closed session. That way you may ask any questions that you feel maybe weren't answered. Okay? Also, before we get in, I'm sorry.
No, that's okay.
If you were a member of the insurance, what was it, the committee? If you're a member of the insurance committee and you're here tonight, would you stand up? And that way we can say thank you for being a part of that there. Thank you very much for participating in that. We really appreciate it. Thank you. Okay, Ms. Valdez, the floor is yours again.
Thank you, sir. I also wanted to add that Miss English will be translating in Spanish as we're going through the presentation. So the group moved over there for those that need the interpretation in Spanish.
Okay, so what I'd like to do is just review the format so everybody understands what we're looking at here. So we should be on the option 1 benefits status quo page, and that's page 7. And what that table illustrates for us on the left-hand side is the name of each plan and each tier of enrollment within each plan. And then down at the bottom is the alternate plan for people who choose not to enroll in one of the district's plans. Okay? And so the next column to the right is the current enrollment in each of those plans by tier. And then we have the current rates, what the employees pay per month based on tier of enrollment, what the district contributes per month, and then the total rate. And if you go down to the bottom of that total rate column, what you see right now is we're generating about $9.2 million in revenue on the plan today. Well, of course, our expenses are coming in, or we're projecting at 11.4. Okay? And so if we were to keep the same plans we have today with the exact same benefits, deductibles, co-pays, out-of-pocket maximums, et cetera, prescription plan, no changes there, the plan would require a 35.6% increase in revenue overall because, again, we're projecting claims to be $12.4 million for next plan year. And with no change in the employer contribution, if you go to the bottom of the employee column, you see that employee rates will increase 240% or $3.2 million in total in change, in change from current contribution. And so this again is an across-the-board rate increase at all rates and all tiers without consideration for whether or not we have a no-cost employee-only option, et cetera. We're just simply calculating the rate increase and shifting that entire increase over to the employee column. Do we have any questions on that?
Any questions so far from the board?
Okay, so this was the one, if we didn't change the plans, what would it cost us to have our plans today? And so then on option 2, the next one, this is a slide that says, hey, none of us can afford anymore, so what can we get with what we're spending today? And we did a plan modeling at Gallagher, and we also had TML do a plan model as well. And they came back with essentially the same plan that we are showing you here today. This one plan that we could afford for all of our covered individuals would be a high deductible health plan with a $6,000 deductible and a $6,450 out-of-pocket maximum. So once your deductible had been satisfied, you'd have another $450 in out-of-pocket expenses to satisfy before the plan paid 100% for the rest of the year. This still includes the health savings account contribution that the district currently makes today, which is just, it's about $500 a year, just under $500 a year for any high deductible health plan enrollee. The district contributes that amount to their health savings account. And so that plan actually would still result in an overall increase of 2.5% or $9.4 million for that plan. Any questions on that?
Ms. Lozano?
Clarify where that would be coming from. That would come from the difference between the current max out-of-pocket to the new?
Well, so what we have, where this plan design itself comes from, it comes from underwriting telling us that based on age, gender, geographical location, and the way we utilize the plan today, this is the plan that we could afford. In other words, The plan would take no responsibility for the first $6,000 on anybody's claims, medical and prescription. And then after that, it would pay 80% until the 20% equaled another $450. And then after that, the plan would pay 100% for the rest of the year. So in essence, it's from a covered individual's perspective, it's catastrophic coverage.
I guess my confusion comes from what I'm looking at that we currently have. The max out-of-pocket is that anyway.
Right.
Just about. So
Right.
what's the difference?
Well, the difference is the deductible. So in today's world, on the basic plan, we have a $750 deductible. On the high plan, we have a $250 deductible,
Okay.
and on the high deductible, it's $1,300. With this plan, it's $6,000 for everybody.
Yep.
Okay. Now, one thing we haven't really talked about in this conversation is we would still keep Ready MD. Regardless of where we end up with any of this, we're still going to have the Ready MD option. And the way that works in today's world, in the PPO plans, the basic and high plans, the covered individual pays $10 and the plan pays the balance, which is $30. If you're a high deductible health plan participant, the rate for high deductible health plan participants is $20. And once their deductible's satisfied, they go back to the $10 copay that the PPO people pay. And that's to access a physician via online, Skype.
How often is that currently being used?
It continues to grow. I'd have to get you the report, but it's been probably the most popular thing we've done in benefits here in the last year, as far as access to care.
And the employees who have used it have really,
Excuse me.
the employees who have used ReadyMD have really expressed their satisfaction with it. But the numbers have increased as Ms. English and Mr. Getz or Mr. Rutledge from TML have gone out to different campuses to educate everybody on ReadyMD. We've had several sessions. Again, the usage has increased. And I haven't heard a single employee say anything negative about it, but the ones who have approached me have said nothing but positive comments about it.
Is ReadyMD set up for urgent type situations, or is it for primary care?
No, they will well, it depends on what you define as urgent. If we're talking true, first of all, not emergent care, obviously, if it's life or limb threatening, emergency room. Urgent care is defined at different levels by different people. You know, if you've got a migraine headache, you could call ReadyMD instead of going to the emergency room and get your prescription. Those kinds of things. So typically it's primary care. We can also do wellness through ReadyMD as well, which is a convenience for folks who may not want to actually go to a doctor's office. They can do it through a virtual platform.
Thank you.
All right, any questions other than these on option 2? Okay. So this next option 3 is that somewhere in the middle. We know we've got to make some changes to benefits, but we also have to make changes in contributions if we're going to pay for the claims appropriately. And so when you look at those benefit options, the sheet we had you tear out, okay? So now we're talking about on the basic plan, instead of a $750 deductible, a $1,250 deductible. And on the high plan, instead of a $250 deductible, a $1,000 deductible. And we're going to try our best to stay with the IRS minimum on the high deductible health plan, which for the next plan year would be $1,350. Okay? The out-of-pocket maximums at the plan level, at the medical plan and the plan level will change. That means that the plan will not pay 100% until the plan out-of-pocket maximum has been satisfied under either of the 3 options. The difference on the high deductible health plan is that for 2018, the maximum out-of-pocket as defined by the IRS will go to $6,650. We haven't heard yet from HHS on the PPO plans. It's strange in that the IRS sets the minimums and maximums on high deductible health plans, primarily because you can use HSA money, pre-tax dollars. But then HHS is the one that defines the things like minimum essential coverage and what maximum out-of-pockets can be on non-high deductible health plans. Okay. And then one of the biggest changes on the basic plan will be that office visits would be subject to the deductible and out-of-pocket. There would not be office visit copays on that plan. In fact, the only plan that would have an office visit copay would be the high plan, and that copay would change to $50, whether it's primary care or specialist. And then, of course, on the high deductible health plan, it's always deductible and out-of-pocket first on those office visits.
Okay.
Yes, sir.
I don't claim to be the smartest person in the room, but when we say the office copay on option 3, the basic plan and the high deductible, high whatever, when we say deductible op, there, whatever that stands
Out of
for.
pocket.
Out of pocket.
Mhm.
So on option 3 for the basic, you're saying the office copay, or you'll pay whatever they want for the office visit?
Yeah, you'll pay
until
the
until you
network
hit-
contract amount.
Until you hit that 6450?
No, until you hit your deductible, which in the case of the basic plan is $1,250.
Uh-huh.
So those network amounts for that office visit get applied to your deductible until it's been satisfied. And then once it's been satisfied, then you go into a cost share with the plan. The plan pays 80%, you pay 20%, and that 20%, that's your out-of-pocket. So deductible's $1,250, the 20% is the out-of-pocket. Combined, that's the maximum plan out-of-pocket of $64.50.
So right now, if I'm on the basic plan and I go to the doctor, I pay $30 for the office visit.
Right.
Option 3, basic plan. If I go to the doctor right after the plan starts, how much do I pay?
Right, it's going to be somewhere in the range of about $80, the network contract amount for an office visit,
Until I hit $1,250?
until you hit
And
$1,250.
then that 80%, or that $80 less 80%.
Right, so you
For
pay
the
20% of that, or $16.
Okay.
Now, of course, again, remember wellness, the routine annual exam, still 100% no out-of-pocket, even on the high deductible plan.
And that's under the current Affordable Care Act?
That's
deems that?
required under all plans
Okay.
to be considered minimum essential coverage. Yes, sir.
So if that got repealed, what happens?
If they change the laws, we would have to, if they just repealed Obamacare, if you will, then we could go back to having, less than 100% benefits on wellness, because we were allowed to do that before the Affordable Care Act. But that's not been our practice in this district. We've always covered the wellness at 100%. And we encourage that because if we can get them in for wellness and we can find something and treat it early before it's displaying symptoms, you know the drill. It's early detection, early intervention, better outcomes, lower cost.
Okay, thank you.
All right, and so back to that slide on option 3. So now what we see is that in order to have these plans as illustrated on slide 6, the rate has to be approximately $11 million. And since we know we don't have any additional revenue coming from the district, that delta between the 9.2 we pay today and this $11 million would be absorbed by employees. And so the resulting rates are what you see on the right-hand side there, where the new basic plan for employee only would be $104.19 per month for employee only. But if you look down at the high deductible health plan, we are still maintaining a no-cost employee-only option. And again, that's in response to the survey results that we received. That it was very important for our employees to have access to a no-cost plan for employee-only coverage. We did not change under the high deductible health plan the HSA contribution. It's still that $500, just a hair under $500 annual contribution to employees who enroll in that plan. And so the rates that we see here are a reflection of some migration in the enrollment as well, because we know we're going to see change in enrollment here based on the new plan designs, right? Traditionally, when an employer rolls out a high deductible health plan for the first time, we see up to as much as 17% enrollment in that plan. Today, you guys have about 2% enrollment in the high deductible health plan. I would attribute that in large part to the fact that the high deductible health plan today is not the only no-cost employee-only plan. You can also be on the basic plan today for no cost. Okay? So the illustration shows us with about 10% going into the high plan, 15% going into the 15%, or it's almost 20% going into the high deductible health plan, and then the balance of folks staying in the basic plan. Yes, ma'am.
Yes, ma'am.
What is the alternate ASO plan?
That's the plan that for employees who choose not to enroll in one of the district's plan, they're given that alternate plan. It's a per day hospital, it's a per diem plan basically, pays them $75 for every day they're in the hospital up to 365 days. Yeah.
What is the max out-of-pocket for family?
Pardon me?
What is the max out-of-pocket for family on each of these plans?
It would be 2 times the individual, so it would be $12,900 on the basic and high, and $13,300 on the high deductible health plan. Yeah, and the maximum out-of-pockets really don't change because those are already limited by things that we don't control. Which we did receive one request to take a look at, we want to keep the copay. Could you just increase the deductibles more? But the reality is that deductible changes versus copays in a plan are not a one-for-one trade-off. The deductible is a lot less impacting than the office visit copay. What we know about changing the deductible, for instance, is that for every $500 we change that deductible, it affects that particular plan by about 2 to 2.5%. But to have an office visit copay on a plan impacts the plan by 7 to 10%. Because remember, with an office visit copay, the plan is paying every time somebody goes to the doctor's office. But if it's deductible and out of pocket, then the plan doesn't pay till the deductible's been satisfied.
So was it cost prohibitive to even look at that, even though, you just explained why you wouldn't recommend it, but.
No, it's not a recommendation, it's the math doesn't work. In other words, we would have to increase the deductible by at least $1,500 minimally on each plan to go with a $50 office visit copay, maybe a $60 or $75 actuarially, depending upon how our recent office visit utilization looks. And again, that's where, like I said, that's where we're really, that's really kind of where we're getting eaten up is on the first dollar expenses. It's not the high dollar claimants because we still, so far this year, haven't had an individual exceed that stop loss deductible. So it is really that general utilization.
But do we need to lower the stop loss amount?
Well, we renegotiated to see what we set it at, but we have to wait for the plan year 10 to get a real picture of where we're going to be at.
And what I would say in that regard is typically so right now the plan takes risk on the first $225,000 on each covered individual. We do have one exception to that on the plan today where we're paying for the first $650,000 on that individual. And typically, you can't come back down lower on that number unless you've had an exceptionally good plan year and the reinsurance companies view your risk similarly, right? And that's unfortunately not the case for us.
Now, when we met with the insurance committee, we did walk them through different examples of employees going from the basic plan to the high deductible plan or vice versa, staying on the basic plan. And one thing that they asked is there is a big increase from an employee who has family going from one plan to the next plan. So they asked us to go back and recalculate and shift some of that change around to the other plans just to see what it looks like. So again, when we presented this to the committee, the only change or the only recommendation for an additional calculation was to take this plan and slightly shift it to where we would still offer a free plan, but the family contribution isn't as high of an increase as it is showing in this scenario. So again, we still have one more calculation that Gallagher Group is working on, and once we receive that, we will meet with the committee again to show them what that would look like. But again, that was something that the committee requested, that we go back and just at least tweak this plan a little bit more.
So there is a potential that the family cost could come back lower. Of course, no? Did I misunderstand that?
That's exactly the reason for the exercise, is we
Okay.
looked at the high deductible health plan dependent coverage rates compared to what their options are today, because we know that by and large, people pick the high deductible health plan because that was all they could afford.
Right.
Okay? And when we look at the $900 rate for family on the high deductible health plan, we know we can't do that. And so these rates are actuarially underwritten so that the plans and the tiers within each plan reflect the risk of that plan. So what we're going to do is we're still going to raise the $11 million in this model. We're just going to shift some of that around. But the dynamic that requires a professional beyond myself to do that is that as we start moving people from one plan to another, that changes the claims risk, right? And I couldn't get far enough down that path by myself without getting into their formulas, and I wasn't going to do that. So we're hoping to have that no later than August 2nd, but certainly before then, if at all possible.
Are there any questions on option 3?
Yes, sir. Mr. Mesa?
I have a question, and maybe somebody from Gallagher can answer that. On specialists, let's say oncologists, cardiologists, what is your standard office out-of-pocket expense until you meet the deductible on
Well,
specialists?
so what we're talking about, I think you're asking what, in essence, it would be the network allowable from those types of docs if somebody was having to go to them and pay for it in full
For an office visit.
for an office visit.
Until you meet your deductible.
So that would be dependent upon the specialist and the type of agreement that they've negotiated with, in this case, United Healthcare's network. But I can tell you that those numbers run $100 to $200, or usually not more than about $240 on a network basis, in that range. But it starts for specialist care right at about $100 per visit.
That's huge.
It's pretty grim.
It's not a good story. It's there are some things that we might have been able to do over the years that we haven't done because we had a fund balance for a while, and we kind of lived off of our fund balance, and we survived the market and our performance within that market based on that fund balance. What we would have probably recommended back then is that even though you had a fund balance, that you wouldn't offset the entire additional risk with the fund, that you would offset some of it with plan changes and revenue changes, and then use some of the fund as well. And so what this is trying to do is get us back to whole, so that we're bringing in $1 for every dollar that goes out. And then in the meantime, we got to get healthier.
Well, my fear is if it's cost prohibitive to go to the physician's office,
Right.
we're not going to be healthier.
Exactly.
That's the fear.
That's
If people can't
the big
afford to go
concern.
to a doctor's office, then their health will deteriorate.
Right.
And the cost will end up being much more significant.
Right. Now, well, that's the point I was going to make. So one of the things that is kind of, that does really complicate our world is the education piece to the end user, okay? Because until people use the plan, they don't know how it works.
Right.
Most people, if they truly understood the high deductible health plan, would be enrolled in the high deductible health plan, okay? I can tell you that people who do what I do for a living, we all are enrolled in high deductible health plans. Not because it's the least expensive plan, although it is, but because we understand it and how it works, but we do this for a living. And so, you know, I've always said to every self-funded group I ever work with, the best asset that we can have as a self-funded plan is an educated end user, because they know what it costs and they know how the plan works. And so I would think that if you had an opportunity to talk to anybody that was on the insurance committee this year, those folks learned a whole bunch of stuff this year. And in the ideal world, and we've talked about this, Ms. English and Ms. Valdez and myself, we're going to be doing high deductible health plan education meetings before open enrollment so that we can get people educated on the program and how it works, because we're going to give you $500. Now, you aren't going to get it January 1st. It gets deposited over time, or do you guys do a lot? You know, it's over time, okay? But what I learned in my first year with my high deductible health plan was I've got this card, and while it doesn't have my whole $500 on it, I'm getting a contribution of like $42 a month. And so, worst case scenario, I can enter into a payment arrangement with somebody for $42 a month, because that's hitting my card every single month, and I know I'm going to have that, right? But the other thing we would educate people on, quite honestly, is if you can, even if it's just $20 a month, put $20 of your own money in the HSA while the district's putting $42 in, because then you'll have an extra $240 at the end of the year that's there that wouldn't have been there if you hadn't kicked it in, and that's going to help you out. And if you don't spend it, it's your money to keep. It just rolls over year over year. But we don't usually get the opportunity to give somebody enough of an education at that level to help them make that leap, because we've lived in a co-pay plan world all our lives. I came from the HMO world. I thought everything cost $5. and obviously that's not the case. But we do know that when our folks go to the pharmacy and fill a prescription, the generics are free. And they don't know what it costs behind that. And it says it on the receipt, but nobody's looking at that. And we understand that. So as much as anything, our biggest hurdle, which has been the same hurdle I've had in this business since I got into it, is educating people on how the plan works.
This is this year, right?
This is this year.
Yeah, and then we'll be in the same dilemma next year.
Well, again, it depends upon our claims. Now, we're out to bid for stop-loss reinsurance, and how that comes back has impact on what we're doing here, because that's a fixed cost. And if it comes back to us like the last renewal with a laser deviation on an individual for $650,000, well, then we're on the hook for a lot more than the $225 we thought we were going to be on the hook for. And that has cost us this year. But there was, that's what the plan's for.
The way I look at, if I model this out, if I look at the losses equate to about $1,400–1,500 an employee, and if you model out option one, basically you're trying to close the gap to get to that $12.4 million cost for next year, which is about $2,000 per district employee. That,
Yeah, so
if you
what'll
model
happen?
that out, if you continue to model that out, it just escalates based on this data.
Right.
So,
If I may add, on the, close to the last two slides, We have a plan for next year to continue the communication, to continue with the committees, to increase health awareness, to increase our sessions with our employees. Again, we want to continue this process so that we're aware throughout the year. But we do have that plan developed as well.
The debt that exists, who covers that debt?
The current deficit that we're forecasting for this year would use up all of our current cash in the fund. Yes, ma'am.
Have there been any, or has there been any thought to not being self-insured?
That is, I get that question in this scenario every single time. And the unfortunate answer to that question is the time to look at being fully insured is when you're healthy. Because the insurance companies are not going to quote you a rate less than this 12 million because they know you're going to spend that. So on top of the 12.4, they're also going to add their profit margin. So, yeah, it's a double-edged sword being self-funded. You get to benefit from the good years, and as long as you planned well and you've managed a good reserve, that's what allows you to suffer the tough years. But like I said, we exhausted our account by the end of this year, and so we are here now, and we got to get ourselves right-sized, get our feet back on the ground, and start looking at a way not just to fund what we're using, but to recreate a reserve if we're, to remain self-funded.
Thank you.
When we talk about what the employee pays going up, where does the grandfather clause for the Affordable Care Act come in that limits that to a certain percentage?
So you all do not have a grandfathered plan, so grandfathering doesn't affect the district's plan. Where we would be affected would be on the affordability piece, the 9.3% box 1 on the W-2. If their cost for employee-only coverage exceeds that number, then we're not offering a plan that's deemed affordable under the ACA.
Okay.
We did also contact the other districts to put together a comparison for our employees of what from 15-16 to the 16-17 to the proposed 17-18 employee contributions and deductibles are for the other districts. So again, on the first area, you can see where we have our district, and next to it we have Laredo, and then Eagle Pass, ISD, and Uvalde. In the second row, we include in there what kind of plan it is, so that as you're looking at the employee contributions and the deductibles, you can relate to where the plan is coming from. For example, SFDR-CISD, we have a basic plan with 80-20, and we'll also offer an HSA plan with 80-20 after the deductible. Laredo offers a plus plan, which would be a very limited network, and a basic plan at 80-20. Eagle Pass offers a basic plan at 80-20 and an HSA plan that's 60-40. And Uvalde is modeled after TRS. So again, this is important to understand, even though it doesn't fully explain and the types of plans that are out there, but it helps with also these are different factors as to why the either deductible or the rates are at other districts. So if we look at Uvalde, for example, TRS, An employee in 17-18, if they want to be on the TRS 80/20 plan, would contribute $415 a month. If they're on the high deductible plan, it would be $52 a month, and so forth. You can see the different plan rates that they have for spouse, children, and family. So we wanted to put this comparison together for our employees so that they can see that at other districts there are also employee contributions, and they could also compare the deductible levels as well with what is currently included in option 3. When we recalculate or tweak option 3, we'll put this comparison together again for what we'll call option 4. But again, this is a side-by-side of the historical trends where you can see that other districts started since back in 15-16 with employee contributions in the plans. And for example, in Laredo, you can see where the employee contribution has remained the same for the Plus plan and for their basic plan. And you can see that in Eagle Pass as well. So again, they do also have plans where the employee contributes to be on a lower deductible plan. And they also have HSA plans as well, where they offer, for instance, an Eagle Pass, and our district is the one in option 3 that we are considering or proposing would be the free plan. So again, this is a side-by-side of those districts that we consider comparable districts. Are there any questions on this chart?
Ms. Lozano, go ahead, and I'll ask.
The difference in the max out of pocket is pretty significant. And that's just because that's the way it has to be in order for us to be able to afford the plan?
No, those are deductible amounts that are listed there. So that's the first dollar expense.
Oh, okay.
Yeah.
Okay, I misunderstood that, okay. Do we know what their max is?
Well,
No.
I'm not sure off the top of my head, but most plans are setting them now because of the
5 or
Affordable
6.
Care Act at the maximum. So $64.50 and $63.50 this year,
Okay,
and then going up next year.
thank you.
Because I know you have the wellness calendar and all that
Yes.
stuff that's next, but before we get into that,
Okay.
how many entities belong to TML that participate in this TML Intergovernmental Employee Benefits Pool?
I'm a former employee there, so I can speak to that. They service over 925 intergovernmental agencies in the state of Texas from medical and prescription claims and benefits perspective within their pool. And I believe right now they have, I think it's 14 self-funded groups, varying in size.
Okay.
And what I can say with respect to TML, when we look at what's going on here from Gallagher's perspective, we're not seeing this as a network issue or a claims administration issue. It's a utilization problem. So whether we go to Blue Cross or United Healthcare proper or Aetna or Cigna, we're still going to have our same people. So the claims aren't going to go away. And we do know that United has definitely competitive network discounts, especially now with you guys being in that Choice Plus network. So we looked at the plan as a whole and decided, well, we know we have to go out to bid for stop-loss reinsurance every year, but we would also like to look at that prescription, that pharmacy spend, because if we think we can save some money there, we got to look everywhere. And so that's why we're taking the pharmacy out to bid. But again, we know that TML did some work with Optum, and they now have a new contract that you all will be taking advantage of if you don't make a move.
The reason I ask, because that's a big pool to be in. And when you look at Texas Association of Counties, TAC, and there's 254 counties in the state of Texas. Not all of them belong to or do what TAC has. but say Valverde County, which is a member of TAC, and they use the program, and they have something that's structured a lot like ours, where there's what we call the free plan, and then it goes up depending on employee and child, and children, spouse, family, et cetera. I'm just curious, because a much smaller pool, and right now, they're about $16 more than what our basic plan is for what we pay right now. They're that $439.95 what we pay, the basic plan for the county's $455.96. The thing that confuses me is their deductible in out is $250 and $500, and co-insurance maximum of $2,000, $4,000. And when you start looking at office visits and emergency room and stuff like that, it's about the same as what we sit at. But I'm just curious as to how something smaller in the sense of pool can have a deductible that is right now currently 500 on each side, 500 less than what we have, and we've got more employees significantly when you look at what the county has. So I'm just curious as to, they pay a tad bit more, but their deductibles are way less. So is it just because of what TAC can offer, or the pool that they're in, or?
Well, in your case, you're not actually in TML's pool. Your claims are administered by TML, but you're not in their pool. They have, like I said, about 935 or so cities and other intergovernmental agencies in their pool, which means they pay a contribution, much like insurance, and that's all they're on the hook for is the contribution amount for the pool members. You guys are a self-funded plan whose claims are administered by TML, and so they charge you an administrative fee. They don't set your rates. You guys set your rates. All they do is process your claims and answer the phone calls and customer service and do the prior authorizations and such through care management. So you're not technically in their pool. I would suspect that the county is actually in TAC's pool, and they're part of a much larger group. So you guys, when we're looking at the district as a whole, you're being underwritten as a group, a standalone group by yourselves. We don't take into consideration anybody else.
Okay. Let's get to the very uncomfortable question. The proposal in option 3 on the basic plan would say that employees would have to contribute $104.19. Unless I'm reading it wrong, please correct me.
That's correct, per month.
$104.19, so $52 a paycheck, right? Because
Yes, sir.
employees get paid twice a month,
Yes, sir.
basically. For those employees that are teacher salaried and making 40+ thousand there and are only on carrying the employee one, there as an example, my wife there, because I carry the kids through, me and the kids through what the state does for the junior college, so she's got the free plan. In theory, hers would go to $104.19 there, and for someone making that amount of money on teacher scale, not as big an impact as, say, the paras and the hourly. And if hourly and para, the basic, what, about 12.5 is what the minimum is about a year that someone makes as an hourly individual, give or take? Because I don't have the pay scales in front of me.
It's close enough for the argument.
Yeah,
Yes.
close enough for the argument, right? So you take that and you divide that out over, we'll just use 12 a year to do that, and that comes out to whatever it is, pre-tax. And then another 104, and it worked out to something like $900 something before we start getting into taxes and all of that. That's the group that I worry the most about with the funding or having to go to the employee contribution. I understand completely where we're at there with the deficit and the cost of health care and this district historically for a very long time has always been, one could say, very pro-employee. They're with providing that free option. They're what we would consider a free option. And that's what's got me very worried right now is those that work hourly and make at or just above minimum and then having to have $104 suddenly taken out, and then that's before we get into taxes and all that. And I know there are others up here that would echo that concern. So I think that's one of the biggest worries that a lot of us up here share there.
When I was a paraprofessional, sir, I took about $200 every 2 weeks is how much I made after insurance. So I understand completely.
So you go in and you figure what that's going to be, and then it starts looking grim. That's my worry right now. And if anyone else has any comments or whatnot, I'll let you speak to that if you want to, Mr. Massa.
It's been historical that, we as board members try to give a raise, and it's eaten up before you actually get your first paycheck with either insurance premiums or something else that goes up, and a cost to the employee. And I wholeheartedly agree that when we look at pay raises, we should start with the hourly because those are the ones that are affected the most. And they work so hard. I mean, from paraprofessionals to clerical, and these are the people that get hit the hardest whenever premiums go up or some other employee contributions that come out of their paycheck. As a result, I mean, they earn very little money for the work that they do. And we try our best as board members to look at all employees and evaluate that when we're making decisions on wage increase. And it's always the hourly rate that are hit the hardest. And it's unfortunate. And even teachers, I mean, it's like we try to give the state mandates. They have this bill that they passed that every district is going to give a $1,000 raise, but no additional money to the district. And so it's hard for us to make decisions sitting up here and look for $1,000 for every teacher with the funds that we have. And so it's a difficult decision for us, but we feel for the employees and every employee, not just hourly wage, but that we try our best to increase the salaries, and it's eaten up by something like insurance or something else. And it's a sad reality, but that's my comment.
Anyone else? Any comment to that before we move on with the other stuff? Okay. Dr. Rios?
Yeah, this is pretty much the culmination of the work that the committee has done. Now we have to go back, and we know how much the plan is going to cost going forward. What the work that remains to be done is how we fit these costs in to the budget going forward. We know what the projected deficits are in the coming years. So now we'll go back, we're going to look at the whole budget and offer different options to the board. These are the options for the coverage. Now we're going to offer different options to the board about how much the district can contribute to each plan. Here we have zero contribution from the district to the increase.
Well, that's the work that we tasked them to do, but now we have to come back and offer different options. Is the district's contribution going to be nothing? Is it going to be a third? What is it going to be? But with the understanding that whatever we are able to contribute as a district, whatever we recommend to the board to contribute, it affects other school programs that we have. So by no means is this final. And then we have to figure out how the salaries work in here and how some of the salaries and increases help offset some of these costs. But over the next month, we'll be very busy creating different options for the board on how to spend our money. So it does look grim, Ms. Lozano, but we're not done with the budget. And we'll be very aggressive this next month in seeing how much we spent over the year and how much we don't have to spend. So it's our turn now to come up with some solutions to make this easier for everybody. Knowing that it's not going to be perfect, it's not going to be 100%, but we'll definitely come up with some options.
Thank you, Dr. Rios, for giving us a little ray of hope. I'm passionate about health. I'm a nurse by vocation. I think health is very important. I would hate to see anyone in a situation where they felt they couldn't go to see a physician and receive the care that they need. So I'm really fearful about that. So I do want to thank the insurance committee members, and I definitely want to thank those who are in the audience. It really proves how important this issue is. Not that myself and our fellow board members didn't already know it, but please know that we will do our best to be as fair as possible. So at least you have my commitment to that. No guarantees. These are very tough times in healthcare in the country. So please keep us in your prayers. Thank you.
Anyone else?
One of the important things when we met with the committee last week was their concern on communication. Throughout the whole year, as we have worked with the Health Insurance Committee, our biggest concern was communication. Our biggest concern is education. So we put a plan together so that they know that we are committed to continuing and increasing the efforts that we have with our Health Insurance Committee and the health plan and wellness calendar. So again, we put a plan together where it shows it month by month. I know this is small to read, but we did put a plan together where it shows it month by month, where every month we will continue to have a newsletter, where every month we will have a health or wellness event, where we will meet with the Health Insurance Committee, and we did ask and urge and encourage the committee that was there, that did participate this year, for them to please continue in the Health Insurance Committee next year, because the knowledge that they gained this year, I mean, is just amazing. They have engaged so much throughout the whole year and provided so much valuable input. We do also have, of course, the health what we call benefit sessions, where we're proposing to start them at the end of August, so that I shouldn't say whatever, but when we do approve a plan, the communication starts immediately with employees, and they all have the opportunity, again, to meet, ask questions, and set up one-on-one sessions. We will, again, one of the committee members that made the proposal to move to 1-1 is where all of this communication, or all of this time is allowed to us for communication. Again, we're proposing to have open enrollment at the end of October, but between the end of August and October, we would have a high emphasis on communication and setting up one-on-one sessions with employees so that we can do our best to educate them. even after 1/1, when we do have when we are going into the plan, we do have sessions set up where TML comes once a month and sets appointments with employees so that, again, we have communication and we would still be continuing with the Health Insurance Committee. We are planning for the health fair. I think the health fair last year that we had was amazing, and we're working on it to be even better this year. And today, actually, we sent out the invite to all our employees that we will have a 3D mammogram bus. So parked here at the administration building for 3 days so that employees could make appointments. Again, we're exploring every opportunity to increase the communication, the education, and continue to have our employees aware of our health insurance plan. And as I mentioned to the committee, this is a template where we want to assure them that the communication will continue. The only date that's set is the health fair because we have so many individuals coming in, but everything else would be up to the committee, but we want them to know that we are committed to continuing with a really good plan and an improved plan as well. And to finish, this was the presentation that we shared with the committee. And at the end of the committee meeting, the two topics that they asked for us to share with the board is what's already been discussed, where can the district increase their portion of the contribution, and can the deductibles in option 3 be reevaluated to reduce the employee contribution amount. So again, the second bullet point is being worked on. That's what we were discussing is going to be the option 4 scenario that we'll look at. But as Dr. Rios mentioned, we would still be looking at the budget in order to analyze the contribution.
Dr. Rios?
I'm sorry, go ahead, sir.
I just have one question directly connected to what you just said. But getting back to what I was describing as the deficit and trying to close that gap, I figured that was about 1,400 an employee to close the gap for last year, and that was somewhere around 22,000 employee to close the gap for next year. So the question is, this option 1 is slightly different than my math, and you indicated that there was a plan in that proposal to put reserve back in place.
That's just to fund that plan and its benefits. We didn't add any corridor for any kind of a reserve because we already knew we were going to be increasing rates 35.6% across the board. So
Okay, so I misinterpreted that piece of it. So there's no plan to build a reserve?
not in this first year, not based on these rates.
Okay, thank you.
I'm sorry, that's dollars and cents, that's the correct answer,
Yes.
but that's just in dollars and cents. The plan to build the reserves is to continue to educate all our employees on making decisions on how they use the healthcare so that we can all contribute to the cost. So we have to have an aggressive plan to make better decisions. And through that, we'll be spending less as a district, and I eventually see this equalizing. If we consider other expenses, like for example, the nutrition program, where the federal government mandated that we increase the price. Well, they scaled it in over a few years. And in the process, it gave everybody a chance to make better opportunities. When we were giving pay raises to paraprofessionals 5 years ago, we scaled that over 3 years. And in the process, made better decisions. Well, the same thing's going to happen, at least in the recommendation we're going to give to the board. We're going to look at the costs, and we know this is how much it's going to cost, but I see us scaling the cost for the employees, or at least from our recommendation, over the next few years, and in the process making better decisions so that everything goes up. We need to build that reserve. Maybe not as healthy as it was because it's very expensive, but definitely build it up over the next few years with better decisions. It's just a long process. But we will definitely have recommendations to the board about scaling these costs over the next few years so that the employees don't see 100% of it right away.
And that was the last slide on our presentation.
Okay. Are there any other questions or comments before we close out the workshop portion and move on to the meeting portion? Thank you for putting all that together. Thank you to the committee for going in and spending the time to do that. As I mentioned earlier, there will be copies in the back if you need any of those. They can pick them up on the way out there, and then after the board goes into closed, if you have questions or whatnot, you can ask Ms. Valdez and the representative from Gallagher there on stuff that was presented. Is there a motion to close the workshop? First by Ms. Lozano, second by Mr. Mesa. All in favor? Closed at 7:40 p.m. Through 5, 6, 7, 8, 9, 10, 11, 12, nothing under any of those. 13, Business and Finance, A, consideration to approve bids, RFPs, and RFQs. 18-01, Retirement Watches. 18-09, Building Material and Supply Discounts. 18-10, Radio Equipment Repair, Service and Parts. 18-12, Water Treatment at Delro High School and Delro Middle School. And 18-13, Auto Parts and Supplies Discounts, Ms. Paula Johnson. If anyone needs any questions on any of those, otherwise I'll just ask for a recommendation.
And County, will you read the recommendation?
It is the recommendation of the administration that the Board of Trustees approve the bids as presented.
Thank you. For the recommendation, I so move. Is there a second? Mr. Smith? Any other discussion? All in favor? Unanimous carries. Thank you. Nothing under Human Resources and Student Services, Technology. It takes us to 16, closed session. Tonight, pursuant to 551.074, discussion of personnel to hear complaints against personnel, and 551.071, private consultation with the board's attorney, discussion of personnel report to include the following new hires and district vacancies, retirements, resignations, and reassignments. 2, discussion of salary adjustments to include but not limited to the following justifications: service credit, master's degree, stipends, salary matrix adjustments. All final votes and discussions will take place in open session. We are now in closed session. Thank you. It's now 8:22 p.m. Wednesday, July 19th. This board will reconvene into open session. No action was taken. A, consideration to approve personnel report to include the following: new hires, district vacancies, retirements, resignations. Aide Garcia.
Good evening, Mr. Overfelt, Dr. Rios, members of the board. It is the recommendation of the administration to approve the following new hires: Juanita Lentz for Dr. Lonnie Green as a third grade bilingual teacher, Karen Hildreth, Del Rio Freshman Campus as an ELA teacher.
For the recommendation, is there a motion to accept? Mr. Mesa, seconded by Ms. Lozano. All in favor? Unanimous carries. B, consideration to approve salary adjustments. There's nothing for this meeting. Okay. Nothing on superintendent's report. Being no further business before this board, is there a motion to adjourn? Ms. Lozano, second by Mr. Mesa. All in favor? Unanimous carries. Adjourned at 8:24 p.m. Thank you.